안녕하세요. 혈치과 원장 박정철입니다.
Greetings, I'm Dr. Park Jung-chul of Kyo Dental Clinic. I am honored to provide a lecture today online. Today I'm going to talk about implant complications and how to respond to them. At present, the implant success rate within Korea is about 95%. By success rate, it does not mean that there are no complications. If you look at this study, there are about 17% of biologic complications. Those with periodontitis, they have higher percentage of complications. And this is because they already had periodontitis before the implants were placed. Regarding mechanical complications, in this study, it talks about 31%. Combining biologic and mechanical complication, it's about 48%. It's nearly half. Among implanted patients, 1 out of 2 have complications. This is a different study, and in this study, about 65% of patients experience at least 1 or more complications. Regardless of the degree of severity, we can note that there is high prevalence of complications. Let's look at when these complications occur and how to respond to them. I'm going to talk about implant complications following the different stages. Because of time constraint, I'm going to talk about complications that can occur before, during, and after surgery, as well as mechanical complications. So 4 different types of complications will be discussed. First is preoperative diagnosis-related complications. You may wonder what I'm talking about. If you do not have appropriate communication, then you would end up in a really big quagmire. Recently, there were news broadcasts about conflicts with patients, so I believe sufficient communication with patients are very important. Before surgery, we need to check patients' systemic health. Patients have different types of diseases, and there are certain factors that we need to bear in mind when we provide dental treatment, so we need to know about patients' systemic health. I've treated this patient in the early days of my practice, and I had to remove the implant. I wondered long and hard about why this implant failed. I was talking with the patient, and the patient told me later that in the past, the patient received head and neck radiation therapy. Fortunately, I did not engage in any dispute with my patient, but it was very difficult to treat this patient. Next, I'm going to talk about complications that occur due to error in diagnosis. There can be radiograph reading error or issues with adjacent tooth, or there could be mistakes in diagnosis. In these cases, implant complications are bound to occur. In the case of this patient, in the sinus number 17, 26, and 27, implants needed to be placed. I think you can read the border of sinus like this, but this is a wrong reading of the sinus border. If you read like this and place the implant, then it could be problematic. The inferior border is positioned like this. If you place implant like this, in number 1727, the residual bone is less than 1 millimeter. Therefore, if you start drilling, in that moment, the sinus will be penetrated, leading to catastrophic results. The strong white line is not the border of the sinus, but is axillary zygomatic process. If you read the x-ray wrong, once you start the implant surgery, then you can find yourself in a really bad situation. In this case, there was a apical lesion in the adjacent tooth, and as implant was placed, due to surgical trauma, it exacerbated. You cannot really see it in the X-ray image, but on the mesial side, on the apex side, you can see that there's a lesion due to surgical trauma. It can be exacerbated, and because of this issue, implant had to be removed and apical incision needed to be made to place the implant. Assessment of adjacent teeth is very important. I'm going to talk about mistakes that can be made in diagnosis, especially when treatment plan is made wrong. In number 37, implant is placed from a different dental clinic. Implant failed. If you look in the oral cavity, it's like this. Number 37, the interarch distance is very tight and the occlusal relations with the antagonist is very unfavorable. If you just place the implant in number 37, in terms of functional aspect, unfavorable results can come to be. I think there needs to be a treatment plan. There should have been a treatment plan how to address these issues, but they were lacking. Implant was provided, but it did not function well. As a result, preoperative diagnosis and treatment plan process is very important in preventing these complications. Next, I'm going to talk about complications that can occur during surgery. There can be many issues. Let's take a look at these factors. Complications during surgery. One of them is bleeding. It can be caused by 3 reasons. Bleeding can occur when a vessel is damaged during surgery or due to the medicine that the patient is taking. Also, the patient's underlying disease can also be a reason. One of the most prominent examples of vessel damage during surgery can be related to lingual concavity due to the position of cerebral gland. If the drilling direction is different, if it penetrates the lingual concavity and causes lingual perforation, the arteries can be damaged, leading to bleeding. You cannot say that lingual perforation occurs all the time, but if you make a mistake, these situations can result, and in severe cases, it can be life-threatening. Therefore, in the case of mandible, we need to check for lingual concavity and make sure that no perforation is made. Drill angulation is very important. Also, another factor is the medicine that patients take. If the patient takes anticoagulant or antiplatelet drugs, there can be excessive bleeding. Some dentists randomly recommend the patient to not take these drugs for a couple of days, perhaps 3 days or a week, but this should not be done. This is a big no-no. In some cases, some patients cannot be off antiplatelet drugs. You need to consult with other doctors and then determine how you're going to adjust the medication taken by the patient. In the Oral Maxillofacial Academy, there were guidelines projected about how to treat patients with potential bleeding tendency. The recommendation is for dental procedures to take place early in the morning and in the beginning of the week rather than weekends. If possible, it should be atraumatic. And we need to check whether bleeding has stopped before we let the patient return home. The extent of surgery should not be too extensive. If it is wide and extensive, then there's higher possibility of bleeding. Therefore, the scope of surgical site should be narrower even if the patient goes through multiple number of surgeries. The surgical site should not be extensive. In the case of pain relievers, NSAIDs, it can lead to other unwanted effects. Therefore, Tylenol or acetaminophen type of drugs should be prescribed. Next, I'm going to talk about nerve damage. These can be caused by multiple reasons. The best policy is to prevent nerve damage. If this occurs, it can be very difficult to treat. The drugs that can be prescribed for nerve damage are shown. Largely, the drugs prescribed can be divided into two. First is drugs for promoting nerve regeneration, and second is for control of neuropathic pain. In order to promote nerve regeneration, pressure needs to be reduced. In order to do that, steroid-type drugs needs to be prescribed in a tapered manner. Vitamin B12 and ATP, which is crucial for nerve regeneration. Also, blood flow improvement medicines such as ginkgo biloba can be prescribed. This is to promote nerve regeneration. Secondly, there is a drug for pain control. As we all know, TCA-type medicine, gabapentinoids are prescribed frequently. Also, minor opioid analgesics can be prescribed. As second-line therapy, SSNRI can be prescribed. Next, second complications that can occur during surgery involves apparatus ingestion and aspiration. In order to prevent it, you can make gauze cotton and prevent it from falling into patient's oral cavity. In the case of driver, you can use string to prevent the patient from swallowing it. This is one prevention method. Also, the patient position should not be so supine. It needs to be uprighted slightly. This can be a prevention method from apparatus ingestion and aspiration. Once the apparatus falls into oral cavity, rather than trying to use forceps to pick it up, you need to turn the patient's face to the side to remove the foreign material, and then use the forceps to remove the material. Once the apparatus has fallen into patient's oral cavity, you need to upright the patient so that the patient can spit it out. If the patient has swallowed the apparatus, you need to send the patient to a hospital where chest PA can be taken. The device position needs to be checked and removed. This is very important. When you do surgery, there can be fenestration or dehiscence. There are a few methods, two methods to respond to this. First is to do GBR to restore this area or to remove the implant, and to change the position of the implant. If implant placement is not easy, you can do surgery later after closing the site. Regardless of the decision you make, what is important is that if you observe fenestration or dehiscence, you need to treat it properly in order to increase the success rate of the implant. Also, primary stability may be an issue in implant placement. Personally, if it is below 10 to 15 newtons, I consider it with bad primary stability. It says 26 newtons here. Also, when ISQ value is under 60, it is considered to have bad primary stability. The choices we have when initial fixation fails is to change to wide or longer implant to get good primary stability, or to choose two-stage surgery. Or you can use materials like allogenic bone to do GBR. Bone remodeling can be gained. Let's look at postoperative complications. Regarding sinus complication and membrane exposure, these will be addressed in separate master courses, so I'm going to focus on swelling and exposure of cover screw. Swelling in patients. This is something that patients worry about, and it's very difficult, the situation from dentist's perspective. Swelling does not necessarily mean that it's a problem. You need to reassure the patient. After 2 weeks, the swelling is reduced. We need to proactively and actively respond to situations where swelling might occur. I provide steroid-type medication to prevent swelling. Next is a situation where cover screw is exposed. This is a problem. When you come across these kind of situations, then you feel baffled. The best way to respond to it is if the primary stability was good, you need to connect a healing abutment. If primary stability was not good, you need to do dressing and make a decision whether you're going to continue on with the situation or to wait for soft tissue healing. If you connect the healing abutment and if there's mobility in implant, then you would have to place the implant again. But just because cover screw is exposed, you do not need to make rash decisions. Next is mechanical complications. It can be divided into screw loosening and fracture, abutment fracture, and implant fracture. Screw loosening. The screws are not engaged. Preload occurs when it is tightened. Once a preload occurs, the screw is tightened. As it functions, there's micro wear. The preload becomes loosened. As preload is reduced, the screw loosening can occur. As you do implant treatment, when you provide cantilever-style prosthesis, or if the implant placement angle is not ideal, screw loosening can occur repeatedly. This is related to implant position, and in the case of screw loosening, you need to look at implant positions. When you place the implant, you need to place it in an ideal position, and when there's a screw loosening, you need to remove it. When there's a screw fracture, you need to remove it. I use an explorer or scaler to do it. I also use ESR kit. If it cannot be removed, screw is fractured here, but I could not remove it in this case. Then you have no choice but to remove the implant body, but it was very difficult to do that. The bone amount was very good here. Therefore, implant screw was grinded off. I made it into a post form, and I restored it with a crown. I think this is one of the way when a screw is fractured. When there's abutment fracture, if you look at ESR kit, there are these types of tools to remove the abutment. You can remove the hex area using this tool. In removing the implant, I'm sure you use this. EFR kit is frequently used to remove implant body, or you can use trap iron burr to remove it. You can also remove implant body almost as if making fulcrum to remove the residual root using elevator. You can connect it with a straight angle to remove the implant body. You can prep bone and remove implant body in this way. If implant is thoroughly removed, you can see that there's crack line here, and that's why it was removed. In this case, ultra-wide implant was used to restore this case. Let me summarize today. Today, I've talked about different implant complications that can occur in different treatment stages. The best way to prevent complication is to use the right product from a good implant manufacturer and to do good treatment. The patient also needs to take care of it. The key is in the dentist. How can dentists prevent implant complications? In a nutshell, I think we need to consider patients' biologics. Biological-driven implant therapy is very important. No matter how excellent technology we have, it is difficult to change biology of patient, and biological-based implant treatment is the only way to prevent complication. I hope we have more chance to discuss on this topic, but due to limitation in time, we were unable to address more factors. In master course offline courses, we will be able to address more contents. Thank you for watching.